Hello everyone, my name is Unurbileg Ochir. Today I'm honored to present our study at Chaled, development of laparoscopic gastrectomy surgery at the NCC Center of Mongolia and the contrast of 2 years. Gastric cancer remains one of the most serious health problems in Mongolia. According to global data, Mongolia ranks among the highest in both incidence and the mortality of the gastric cancer. And additionally, approximately 1 in 20 people in Mongolia are at risk of developing all types of the cancer, with even higher risk among the men. It's shown on this side. And this graph shows the increasing trend of the gastric cancer incidence and mortality over the recent years and highlighting the growing burden on the bar chart. And in the right side, one of the major challenges is the late diagnosis in Mongolia. As shown in this chart, more than 60 of the patients are diagnosed at advanced stages that the third and the fourth stage together make up the majority. And in recent years, the Mongolia has been transitioning toward minimal invasive surgery. In addition, the National Cancer Screening Program, introduced in 2022, has improved the early detection and created more opportunities for curative surgery. Therefore, this surgery aimed to evaluate the development of the laparoscopic gastric cancer surgery by comparing the surgical volume and the short-term outcomes between the 2 years. And we conducted a retrospective study at the NCC of the Mongolia from the 2023 to 2024, analyzing the laparoscopic gastric cancer surgeries in terms of the volume and the perioperative outcomes between these 2 years. And this bar chart shows the total number of the surgeries and laparoscopic procedures underwent in our hospital. In 2023, the 37 cases, or the 12.8%, were the laparoscopic, but in 2024, this increased to 75 cases, that are the 24.7% of the all cases became the laparoscopic. That means that nearly doubled within the 1 year. And this figure shows that the distribution of the laparoscopic procedures. In both years, the distal gastrectomy was the most common procedure. However, also other procedures like the legs and the total gastrectomy is the growing. And more the endoscopic treatments such as the EMR and the ESD are also increasing in Mongolia. Currently, around the 80 to 100 procedures are performed annually at our center, and the 20 to 25 the percentages of the newly diagnosed gastric cancer cases per day treated by the endoscopic treatment in the national data. And now we're gonna look the key outcomes. The overall complication rate decreased significantly from the 9.98% in 2022 to the 3.06% in the 2024. This is now within the international standard range. Then reoperation rates slightly decreased, and the 30-day readmission is remained low. That importantly, the mean hospital stay shortened from the 7.05 days to 7.9 days. And so now we're going to talk about the outcomes of the laparoscopic gastric cancer surgeries and separately. And of the 84 patients analyzed, and the most were male, and the tumors were predominantly located in the antrum. The mean operation time was 181 minutes. And this, in these tables and the charts, shows that the tumor stage correlation between tumor stages. The most patients presented with advanced tumor and the node stages. Again, this is reflecting the late diagnosis. As shown on the tables, the second and the third grade tumors were top in all cases. And about the mean operation time, decreased from the 189 minutes to 175 minutes in these 2 years. And when comparing operation time in the hospitals, there are no significant decreases in these 2 years. And about the histology result, in these 2 years, the most patients presenting with moderate to poorly differentiated adenocarcinoma tumors. And about the post-operation time, there is no strong predictors were identified in all laparoscopic surgeries, but for hospital stay duration, age, and the tumor grade is affected the hospital stay duration. That means the older stage and a higher tumor grades increased the hospital stay duration. In 2024, in the last few days, in our hospital, we improved the oncological quality by expanding the extent of lymph adenectomy. The 30% of the cases included the D2 and the D2 plus lymph dissection, and rest of the dissection was the D1 plus and a D1. And we introduced it to the routine use of the indocyanine green to enhance the lymph node dissection. And this video shows a laparoscopic total gastrectomy performed with using indocyanine green guidance, which we routinely use in our practice. Okay. Our findings demonstrate the rapid expansion of the laparoscopic surgery in the development country settings, and importantly, this expansion was accompanied by improved outcomes, suggesting increased surgical skills and better perioperative management. And our center has actively developed the minimal invasive gastric surgery and expanding the laparoscopic capacity. As the next step, we have introduced a robotic surgery training with the system installed in our training facility as shown in the picture. And this reflects our commitment to advancing the surgical care in Mongolia. And about the concluding our study, the laparoscopic gastrectomy expanded from the 2023 to nowadays with improved outcomes and reduced complications. Thank you for your attention.
Okay, good afternoon, everybody. My name is Chaled Alnakib. I'm from Israel. I'm from Volson Medical Center from Israel. I'm doing my fellowship. I'm completing my fellowship here in the gastric surgery in the NCC Korea. On behalf of my team, that Professor Shimonov cannot be here, so he is the head of the general bariatric surgery at my institution, and is the president of the Israeli Society of Metabolic and Bariatric Surgery. So I'm going to talk about some issue that not all the doctors talk about it. A little bit of background. The most effective long-term treatment for the morbid obesity is the laparoscopic bariatric surgery. So from IFSO Global Report 2025, we have more than 500,000 operations a year, and all over the world we have more than 2.5 million operations. Most of the operations are the sleeve gastrectomy, Roux-en-Y, and mini gastric bypass. And the evidence-based benefits is better for the weight loss and the D2 readmission and the lower cancer risk and lower CV events. So more operation we have, more complication we have. And one of the most important thing that we have to say is the severe late complication. The severe late complication can be very easy, from very minor to life-threatening complication. Rarely we have just isolated one complication. We have, in our study that I will show right now, we have 72% of the patients that have multiple complications. Last resort, always don't forget that the reversal anatomical reconstruction is always the last thing that we have to think about it after the failure of our weapons, like the conservative, endocrine, gastroenterologist, and the management. So what anatomical reconstruction? In our cohort, we have mini gastric bypass and Roux-en-Y gastric bypass. The common thing between the both procedures that we have the pyloric exclusion, and we have the very fast bypass food from the stomach to the intestine. So we have, we will talk about the pathophysiology in a second, but we have more risk to have in the future, like the post-bariatric hypoglycemia, hyperinsulinemia, the severe malnutrition, the marginal ulcer, esophagitis, and anastomotic complication. So what the world talk about it, the International Society agree, like the IFSO and the ASMBS, plus joint statement from 2022, and the EAES and the IFSO Delphi, like the consensus 2023, all agree about the anatomical reconstruction, but we have no indication or algorithm for this issue. So the gap, the critical gap for this study, for this work is there is no society that publish any specific indication for the anatomical reconstruction, no standardization operative algorithm, and there is no published data. There are very small single center series. If I will present my study talk about the single center study from Volson Medical Center. We are a retrospective consecutive case series. We have just 11 patients. It's a lot for this. I think that it's a lot for this study. All the patients were included. There is no exclusion for the patient, and our outcome were 30 days safety that we will see the results right now, the symptom resolution and the weight change, and the post-bariatric hypoglycemia, hyperinsulinemia biochemical response. So the patient characteristics, like 11 patients, 9 women, 2 men, mean age 49, and the direct reconstruction is 63%. And the index bariatric procedures was the mini gastric bypass, nine patients, and with the Roux-en-Y, and the sleeve gastrectomy, 2 patients. We can see that, but we can see that the BMI, the primary surgery, was 42.8, and before the reconstruction was 21.4. The mean interval to reversal was 4 years almost. And as we can see, 4 patients had a BMI less than 20 before the operation. So 72% of the patient had a multiple complication, like the marginal ulcer disease, the post-bariatric hypoglycemia, the severe malnutrition, the reflux, and the anastomotic leak. And there is no patient that had just one complication. Move forward to the post-bariatric hypoglycemia, hyperinsulinemia. It's very rare. The pathophysiology is very simple because we have a pylorus bypass, we have a rapid gastric emptying, we have very high GLP-1, very high GLP-1 in the blood that stimulate the insulin, so we have hyperinsulinemia, and that provocate the hypoglycemia, and the patient can have seizures and neuroglycopenic symptoms. So our diagnostic criteria for our patient was the postprandial neuroglycopenic syndrome, and patient that have bariatric surgery months or years before the surgery. The glucose nadir like less than 60 milligram, insulin very high, and the failure of 2 non-operative treatments. So insulinoma was excluded with the IV OGTT and the CT that I will show right now. As we can see, the difference between the hypoglycemia vs insulinoma with these patients, we can see the difference between the OGTT and IV GTT. And some doctors, some bariatric surgeons ask why you go to surgery without do pharmacological treatment. So first of all, we have to try to give this pharmacological treatment. It's like the modification of the diet, the SGLT2 inhibitors. It works, but it not so much works. We have the Exendin 939, the GLP-1 antagonist. It's perfect for the isolated post-bariatric hypoglycemia, hyperinsulinemia, but as we said, 72% of the patient have multiple complications. So it's not helpful for the other patients. So reconstruction is the only option when we have all this mixed complication. So our postoperative outcomes is, we can see that 100% of our patients had symptom resolution of the marginal ulcer and the chronic diarrhea, and 75% of the post-bariatric hypoglycemia. I will talk about it in a second. And 87.5%, the malnutrition was resolved. Okay, and the BMI was increased from 21 to 24. And as we see, the biochemical and the clinical outcomes for the post-bariatric hypoglycemia, hyperinsulinemia, 75% of the patient was complete resolution. So we can see that the pre-op before the operation, the peak of the insulin was very high. Also the C-peptide and the glucose was very low. And after the operation, it was very low, and the post-operation of the glucose was good, was high. So we can see the resolution that was perfect for these patients. Um, the take-home message, so it's laparoscopic anatomical reconstruction is safe and feasible. We need a multidisciplinary approach, the endocrine, the gastroenterologist, the nutrition, the surgery, and that's it. Thank you very much.
Good afternoon, everyone. Thank you for having me. My name is Thanat Tantinam. I am a colorectal surgery fellow at Ochir Hospital in Bangkok, Thailand, and I previously served at a general surgery unit of Phatthalung Hospital in southern Thailand. Today, I will present our retrospective non-inferiority study examining whether laparoscopic inguinal hernia repair is feasible and safe when performed by recently graduated surgeons. I have no disclosure for this presentation. When I was a resident, a senior surgeon told me, "You must master open surgery first. Only then you can touch the laparoscope." Many of us heard the same words. I felt like a rule that could not be questioned. But today, most surgery are done laparoscopically or robotically. Open cases are becoming rare, even during training. So I want to ask you the same question I asked myself back then. If we rarely do open surgery anymore, how can we ever master it first? This is what we call the modern trainee's dilemma. During residency, trainees have less hand-on experience than before. Safety rules and hospital standards have reduced resident autonomy. Because of this, many young surgeons do not feel confident to perform advanced laparoscopic procedures or operations on their own. They can do only cholecystectomies or appendectomies, but not much more. As a result, many rely on fellowship training just to reach basic independent level like me. This is a real problem for new graduates. There is also a long-standing belief in surgical training that you must learn open surgery first before doing laparoscopic surgery or robotic surgery. This is not just a tradition. Major guidelines from SAGES or JSAS clearly state that open skills is required first. But we should ask again, is this still true today? Most surgeries are now done laparoscopically. That it still makes sense to require open surgery before allowing laparoscopic practice. This is our study's aim. We wanted to show that laparoscopic hernia repair is not worse than open surgery, even when performed by a new surgeon without open hernia experience. In short, we aim to challenge the idea that open skill must come first. We conducted a retrospective cohort study at Phatthalung Hospital, which is the provincial hospital, a secondary hospital. Patients who had inguinal hernia repair were divided into two groups, open and laparoscopic repair. All operations were done by the same recently graduated surgeon. The main outcome was the complication rate. We used a 15% non-inferiority margin. This means we tested whether laparoscopic results were close enough to open results within this margin. This table shows patient characteristics in both groups. Age, sex, BMI, SA score, hernia type, and size were similar. There was no significant difference between two groups. This means our comparisons in this study is quite fair. Here is our main result. The open hernia group had a complication rate of 26.7%. This included one supraumbilical cord injury during surgery. The laparoscopic group had a lower rate, 19%, with no organ injuries during surgery. The p-value was 0.5, which means the difference was not statistically significant. This is key finding. The new surgeon performed laparoscopic hernia repair safely, even without prior open experience. One trade-off was the operative time. Laparoscopic repair took longer time, which is expected for a new surgeon. However, this extra time did not cause worse outcomes. And as experience grew, the operative time became shorter and shorter. This shows a normal learning curve for a new surgeon. These are our non-inferiority results. For all major complication categories, laparoscopic repair stay within the 15% non-inferiority margin. This confirms that a recently graduated surgeon can safely perform laparoscopic hernia repair without compromising patient safety and without prior open hernia experience. To summarize, laparoscopic hernia repair is feasible and safe for new surgeons. Complication rates were similar, with a favorable trend for laparoscopy. Operative time improved over the time. All non-inferiority criteria were met. Of course, we must acknowledge our limitations. This was a single-center retrospective study with a relatively small sample size performed by only a single surgeon. These factors limit the generalizability of our findings. Larger, multi-center prospective study would strengthen this evidence. However, our results provide a good starting point for this view. In conclusion, ladies and gentlemen, the open first rule is a myth. Starting surgical career with laparoscopy is safe and feasible. Our data shows that open mastery is not required for safe laparoscopic hernia repair. But this is just the beginning. I hope the future studies will continue to challenge this myth, not only with larger sample sizes, but also in more complex procedures or operations, for example, colorectal surgery or gastric surgery. If we can prove this across different operations, we can reshape how surgical training is designed and give the next generations of surgeons a better and a more confident start. Thank you for your attention. I'm happy to take any question.
Dear professors, good afternoon. I'm Binbin from Huadong Hospital, China. It's a pleasure to present our study here at this conference. My topic is genetic correlations among diaphragmatic, femoral, inguinal, ventral, and umbilical hernias, and identification of their candidate genes. As we know, hernia is a common surgical condition with strong familial aggregation, but whether different hernia subtypes share a common genetic basis remains unclear. So our study had two aims. First, to qualify genetic correlation among 5 major hernia subtypes. Second, to identify shared candidate genes. This is our method. We used Finnan-Juwas data for diaphragmatic, inguinal, femoral, umbilical, and ventral hernias. We first applied ALD score regression to estimate genetic correlations. Then we used EQTL data to perform Mendelian randomization. After that, we did Bayesian colocalization. Finally, we validated the result at the protein level. This is our result. Figure A shows genetic correlation coefficients between different hernia subtypes. The closer the value is to 1, the more similar the genetic basis. You can see that umbilical and ventral hernias have an RG of 0.78, and inguinal and femoral hernia have a range of RG of 0.77. They both indicate strong shared genetics. In contrast, like these, diaphragmatic hernia shows weaker correlation with others, suggesting a more distinct genetic background. This finger B is a Venn diagram. We can see inguinal hernia and hernia of the abdominal wall shared 4 genes. Our key genes are BMP6, MYCB, PAP, ZNF75A, and this shared gene supports the idea of a common genetic basis across hernia subtypes. This is finger 3 is MR analyzed result for shared candidate genes. 7 candidate genes associated with multiple hernia subtypes were identified through Bayesian colocalization. Using this method, we confirmed the robustness of these 7 genes. We also performed validation using fibroblast EQTL data from GTEXV10. The result shows that our key genes maintain the same direction of infect as in blood EQTL analyzed, further supporting their robustness. So in conclusion, first, different hernia subtypes share a common genetic basis. Second, BMP6, MYCB, PAP, and ZNF75A are key shared candidate genes. Third, higher BMP6 protein levels are associated with lower hernia risk, indicating a protective role. Also, of course, our study has some limitation. First, all data are from European population, so the findings may not be generalizable to our ethnic groups. Second, femoral hernia had a small sample size, which may reduce statistic power. Third, the mechanism of MYCB, PAP, and ZNF75A are still unclear and require further function study. Thank you.
My today's presentation is a prospective observational study on early outcome of laparoscopic TAM repair with hernia sac assisted mesh coverage for incision hernia at Tertiary Care Center. Myself, Dr. Vikram Saini, working as an assistant professor at All India Institute of Medical Sciences, Bhatinda, India. I bring greetings from India. There is no disclosure. So the background, my study is about how we can preserve the anatomy of an abdominal wall without doing a massive destructive kind of techniques. So my studies focus on moderate to large ventral hernia repair with the option that we can do a moderate to large ventral hernia repair without doing a component separation, that is posterior component separation, and a tension-free closure of ventral hernia. So our aim is to use this technique, a new technique, to remove TAR procedure in complex and potentially, because TAR procedure is bit destructing procedure which removes transverse abdominis muscle, which is also a component of abdominal wall. So my focus is tissue preserving technique which utilize already present tissue, that is hernia sac. So objective is to assess post-operative outcome, complication, and recurrence with this technique, and to compare its outcome with already published literatures and to establish role of this technique as a minimal SS alternative to TAR. So in this study, I have taken 5 cases. Mean age is 52 with BMI of 26. All of these patients are in cases of incisional hernia. There was already 5 cases already undergone gynecological surgeries. One case was is a recurrent hernia after laparotomy and previously operated hernia repair, open hernia repair. So to summarize, the median of EHS classification, that is most of the cases are M4, and the defect size is 6. It's vary from 5 to 6, so 6 centimeter. And we took a mean operative time of 130 minutes, and we use in all these cases, because it's medium size hernia, we use 15x15 mesh. These are the some points how we start our surgical techniques. We will include these points in a video which will attach in this slide, next slides. So let's start with the operating room setup and the port position. The port position is we took 10 mm port around 2 finger above the umbilicus and 2 5 mm port around the umbilicus. This is video showing a large hernia. Hernia with there is mesh is also visible. This mesh, and this is the hernia sac, a large hernia sac we can see. Now, as in TAM procedure, in this case on the right side we incise and go in the retrorectus space. So just a minute. So we divide it and go retrorectus space. Then we press this hernia sac from externally by giving an external pressure and hold the hernia sac. Then after holding, this is how we create a retrorectus space on one side. Then we hold the hernia sac, pull it down, and cut one edge of the hernia sac. So we cut the one edge of the hernia sac. Now we cutting the one edge of the hernia. You can see the previous surgery mesh is already there. So we take this hernia sac. The length of this hernia sac is taken around the same length of the hernia defect. So it is taken out, and there is, you can see in video, there is the hernia sac is still in continuation with on other side. So it is cut from one end, and there is still continuated with the another side. So the length of this is taken similar to that of the defect. Now this hernia sac, we use it in utilizing for the posterior closure. The blood supply is now we close the defect, and this is tension-free closure of the posterior layer. Now we will add the mesh, and this sac is preserved in the posterior layer, and we suture it. So we assess the pain assessment, and we found out that in postoperative grade, the median was 4, which lowers down as we follow up till 6 months and annually. Postoperative complications. Though our follow-up was median of 10, we follow patient from 9 to 10 months, and we are still, patient is still following up in our OPDs. We do not experience any recurrence, any chronic pain. 60% of our patient experience seroma formation. Otherwise, There is return to activities 8 days, and there is requirement analgesia duration 4, and the pain score is 3 and 4. Hospital stay is 3. So in literature, there is another similar study, which is by Balchandran et al. The similar study used ETP procedure for the and utilizing hernia sac for posterior closure. The sample size was 3 in these cases. So our studies have a similar outcomes. There is no recurrence till now, and there is minimal morbidity, and we can successfully do surgery without doing a transverse abdominal muscle release. So in discussion, there is median VAS score is low, and there is no chronic pain after follow-up 10 months. Seroma is present in 60% of cases, and all these cases, it is managed by just abdominal binder without using, without any aspirations after 1 month of follow-up. So nowadays there is growing interest in tissue preserving strategy to achieve posterior layer closure without dividing muscle and nerves. So it's a simple procedure which utilize already present tissue rather than cutting the transverse abdominis muscle, which is a part of very important part of an anterior abdominal wall, and it is also comparable to already present published literature. So we have limitations because sample size is very small for only 5 cases, and which includes M4 and M5 kind of hernias. And this study is performed by a single operating surgeon, and the follow-up is 10-month median, and it need a large multicentric studies for long follow-up and required for validating the recurrence rate. And we are following our patient, and patient is following our own 1 year, after 1 year, and our findings support tissue preserving strategy. Concluding remarks, it is a feasible, safe, and effective for large ventral hernia 5 to 7 centimeters. There is no recurrence in 10 months follow-up, and it's a wide technically demanding TAR, transverse abdominal muscle release procedure, and is cost effective and a minimalistic techniques. Thank you very much for patience listening.
First of all, I would like to thank the organizing committee for the opportunity to present our experience in laparoscopic treatment of hepatocellular carcinoma. We have nothing to disclose. At present, laparoscopic liver resection is considered the standard surgical treatment for many types of focal liver lesions. A large study from Asan Medical Center demonstrated that tumor size and the need for combined resection were the main limitation for selecting patients with hepatocellular carcinoma for laparoscopic resection. As you can see, despite the use of propensity score matching, patient selection into the laparoscopic approach remained influenced by patient age, the presence of comorbidities, tumor size, tumor numbers, and adjacent structure involvement. Notably, under these selection conditions, the authors observed an improvement in both overall survival and disease-free survival in the laparoscopic group in this study. Similar criteria for patient selection have been demonstrated in our big data analysis studies. At the same time, two key questions remain unanswered, which perioperative parameters represent absolute contraindication for the patient hepatocellular carcinoma to laparoscopic access, and under that specific condition, the use of this approach is considered safe and feasible. The aim of our study was to identify the group of patients who would benefit most from laparoscopic approach. We analyzed the outcomes of textbook outcome in our center series of 116 laparoscopic resection for hepatocellular carcinoma and compared them with 76 open procedures. The laparoscopic group had fewer comorbid patients, less advanced disease, smaller tumor size, lower rate of multiple tumors, and lower major and combined resection. Improvement is in many immediate outcomes in laparoscopic group was expecting, but the main reason for was patient selection. Overall disease-free survival were also better in the laparoscopic group. Again, the improvements in survival should be attributed to patient selection. We used textbook outcome achievement evaluation to clarify finally the cohort of patients most suitable for laparoscopic approach by calculating the surgical risk. We used one of the validated TO model, which was defined as H0 resection, absence of intraoperative complications, absence of severe morbidity, no readmission with 30 days, and no hospital mortality. Logistic regression revealed the predictor of non-achievement textbook outcome, which includes tumor size more 10 centimeter, equal status free, T4 stage of TNM, BCLC stage C, proximity to major vascular structures, and combined resection. Next, patients were allocated into a free group based on the presence and number of negative predictor of textbook outcome achievement. As you can see, the first group is represented by patient without negative predictors, the benchmark group. Criteria benchmark group, as you can see on this slide. In benchmark group, without negative predictor of textbook outcome achievement, patients were selected for laparoscopic approach based on the number of tumor and the history of prior abdominal surgeries. Notably, this group had the lowest rate of open procedures. In this group, laparoscopic resection demonstrated a reduce on the length of hospital stay. The remaining immediate postoperative outcome did not differ significantly between the surgical approaches. Overall disease-free survival were also better in the laparoscopic group, which is likely due to the lower number of patients with multiple tumor in laparoscopic approach. The second group, group 2, including patients who did not have T4 stage, BCLC stage C, or combined resection, but who had at least one and over negative predictors. The number of patients in this group who underwent laparoscopic surgery was approximately equal to who underwent open surgery. In this group, there was also a selection for laparoscopic approach based on the tumor size and number of tumors. Under the specified patient selection criteria, laparoscopic approach demonstrated a decrease in blood loss, postoperative morbidity, and length of hospital stay, as well as an increase in the rate of textbook outcome achievement. Overall, disease-free survival were also better after laparoscopic resection, which was most likely due to smaller tumor size and less number of patients with multiple tumors in laparoscopic approach. A group was also identified in which one or combination of the following factors was present: T4 stage, BCLC classification, or combined resection. This group had the fewest patients who underwent complex, extensive combined surgeries, and no laparoscopic procedure were performed in this cohort. In conclusion, laparoscopic resection, in our experience, and recommend for patients in the benchmark group, especially in patients who have solitary liver tumor and no previous abdominal surgery. Laparoscopic resection is possible in patient intermediate risk group. Is also possible with the following parameters: tumor size less 10 centimeter, limited multifocal disease, 2 maybe 3 lesions, and patient who has hepatic invasion for hepatic veins reconstruction needed is technically feasible. And laparoscopic resection is not recommended for patient at high risk group. Thank you for your kind attention.
Thank you, Chairman, for kind introduction. I have no COI. Advances in surgical technology have made medical video data from the procedures like the laparoscopy, endoscopy, and robotic surgeries. These videos are multi-purpose roles, including the documenting procedures, guiding technique, improvement, and research. However, current medical video management is unstructured, lacking the clear standards, posing risks to data reliability and patients' rights. Aim of this study is to establish effective guidelines, the management and the utilization of medical operating videos by eliciting consensus among diverse stakeholders on key principles, procedures, and the responsibilities. To develop the practical and broadly acceptable guidelines, we use the Delphi survey method. This approach was selected to systematically collect expert opinions and build consensus among diverse stakeholders involved in medical operating videos. Expert panels included the surgeons, hospital directors, educators, patient group, and lawyer. Participants reviewed the structured questions covering the video data collection, storage use, and the related legal and ethical issues. Regarding the data collection and storage, expert panels have questions for the consensus to develop the guidelines as below: complex and the variable consent, procedures, risk of involuntary consent, the need for the standard purpose, scope, custodians and format, metadata, selective the de-identification of voice data, role-based assess to control, clear responsibilities, retention and disposal standard, and the procedures for post-human viewing the deletion and the request. Regarding the data and secondary use, personal data should be deleted for education, research, or industry use. Purpose-specific use standards are required. Clear boundaries for editing and reuse. Secondary use consent should be obtained at collection. Traceability and usage logs needed to prevent the distortion. Regarding the legal ethical issues and consensus level, divergent views on video ownership, disagreement on handling patient viewing, deletion, request, unclear roles and the responsibility across stakeholders, a need for a multi-stakeholder coordinating body. Most items reached consensus. A few did not meet the convergence. This the busy table for the we performed the second and then this third survey for the questions after first survey. To summarize the result of this survey, we evaluated both the level of the agreement among the responders and the degree of the convergence across responses. Overall, the majority of the questions met the predefined the criteria. This means indicating that stable consensus was achieved for the most guideline components. However, a small number of questions did not reach sufficient convergence. The remaining issues are about collecting medical videos without prior consent in emergent situation and no exception with mandatory and explicit prior consent. Also about the data management system for ensuring patients access to their own data and the right to withdraw the consent did not achieve the consensus. The voice recording and the voice video recording continuation in emergency situation and the commercial use decrease the consensus level between 2 and the second survey, like this. And also the request for the video deletion decrease the consensus level between second and the third survey. So I conclude. The expert panels has consensus data collection, storage use, secondary use, legal and ethical issues, and consensus level are important issues. Most questions about important issues achieved consensus, except the video collection without a prior consent and the data management. So the guidelines for medical operating video management and utilization will be necessary in near future. And I thank all the experts, the surgeons and patient group and lawyer, hospital director, educator in hospital that participated in their survey. Thank you for your attention.